And I just want to welcome everyone today. We've got some really good issues to discuss, and I want to give my committee some time to make some introductions. Representative Weber, do you have somebody?
I do. Thank you, Madam Chair. I would like to recognize Matt Deneen here today. Matt is a member of the Elizabethtown City Council, but come November, he will be the new state senator for the 10th District in Hardin and Southwest Jefferson County. He is unopposed going into the Senate, and I'm looking forward to working with him and have gotten to know him over the last few months, but want to ask the members of this committee to welcome a gentleman who will be a new senator come January of 2023. So welcome, Matt.
Thank you, Representative Weber. Secretary, please take the roll, and we'll go ahead and get started.
Representative Bentley.
Here in the room.
Representative Bowling. Representative Bray.
Present in the room.
Representative Birch. Representative Dotson.
Present.
Representative Elliott. Representative Fleming.
Present in the room.
Representative Frazier Gordon.
Present in the room.
Representative Marzian. Representative Gibbons Prunty.
Present in the room.
Representative Rayburn.
Present in my home district.
Representative Raymond.
I'm here.
Representative Riley.
Present.
Representative Sharp.
Present.
Representative Sheldon.
Here.
Representative Tate. Representative Weber.
Present in the room.
Representative Westrom. Representative Wilner.
Here in the room.
Chairwoman Mosier.
I am here in the room. Okay, we have a quorum and are duly established to do business. I would like to just reiterate our welcome to the future Senator Deneen. Thank you very much for being here, and congratulations. You have it's a great accomplishment to not have opposition, so congratulations. Okay, I just want to remind all members to silence your phones. Everyone knows the drill, I think. And the members who are on campus and in person are our voting members today, just as a reminder. So we will go ahead and get started with House Bill 227. Welcome, Representative Hart. And I don't know if you have any guests, but introduce yourself and please proceed.
Representative Hart, 78th House District, and the bill I'm about to present, I worked on with Representative Massey. Unfortunately, he got tied up in Louisville, but I wanted to give him a shout out. We worked on this together, and you've got it in front of you. It's very, very, very simple. What this bill does, it establishes the first Saturday of October of each year as first responder, doctor, nurse, and healthcare professional days.
Motion on the bill.
Second.
We have a motion and a second. Do we have any questions or discussion? All right, seeing none, Madam Secretary, please take the roll.
Representative Bentley.
Yes.
Representative Bowling. Representative Bray.
Yes.
Representative Birch. Representative Dotson.
Yes.
Representative Elliott. Representative Fleming.
Aye.
Representative Frazier Gordon.
Yes.
Representative Marzian. Representative Gibbons Prunty.
Yes.
Representative Rayburn. Representative Raymond.
Yes.
Representative Riley.
Yes.
Representative Sharp.
Yes.
Representative Sheldon.
Yes, great presentation.
Representative Tate.
If I may, I would like to file a presence and also a vote yes.
Thank you. Representative Weber.
Yes.
Representative Westrom. Representative Wilner.
Yes.
Chairwoman Mosier.
Yes, ma'am. All right.
I wouldn't steer you wrong.
Representative Bowling, would you like to register a vote for House Bill 227?
I'd like to register, yes, ma'am. Like to register a yes vote for House Bill 227 as well as a present vote for committee.
Thank you. Okay, House Bill 227 passes with favorable expression. The same should pass on the House. Congratulations and excellent presentation.
Thank you, Madam Chairwoman. If only all bills were this easy.
Well, I'm going to come down to the table and present two very simple bills.
I don't know if they'll be that simple.
We're going to go a little out of order. We're going to do House Bill 525 first. So if any guests coming forward for 525 want to make their way to the table. Welcome. Introduce yourselves for the record and proceed.
Okay, thank you very much, Madam Chair and committee. I am State Representative Kim Mosier, representing the 64th District, and I'm very happy to be joined by some wonderful community health workers this morning and experts in this field, and that's what we're going to talk about today. This is House Bill 525, and I just want to talk a little bit about, just briefly, about what community health workers are. They are certified healthcare workers embedded in primary care clinics, health departments, FQHCs, community mental health centers, hospitals, and they work in the communities in which they live. They really get to know their communities. They know...
Can you get the microphone just a little closer?
Sure, yeah. Thank you. So they really understand their communities. They're trained health educators and navigators who meet individuals where they are. They understand individuals' healthcare journey and help them navigate a sometimes really daunting system. There are many reasons, as we know, why individuals don't access the care that they have available to them. We have expanded Medicaid to almost a third of our population here in Kentucky. We have 1.6 million enrollees in Medicaid, and we have not moved our health metrics. We continue to have high rates of diabetes, heart disease, smoking, a lot of issues that we know that community health workers can really help educate folks about. So, you know, I think some of these ladies are going to discuss some of those barriers, but, you know, lack of transportation oftentimes, fear, just a inadequate health literacy, understanding of even insurance forms. So well, I talked a little bit about our Medicaid expansion, so I don't feel like I need to go into that any further, but we know that it's time, because of this Medicaid expansion, to really get more targeted with our Medicaid dollars and work on programs that work. We have had pockets of community health workers throughout Kentucky for probably close to about 20 years, I think, through the Kentucky Home Place. And the Kentucky Home Place did a study over that period of time that really analyzed the usefulness of community health workers. It was very successful and showed about an $11.30 return on investment for every $1 invested in Medicaid dollars. So it's really, the cost-benefit analysis has shown it to be a very productive use of our taxpayer dollars. So what this legislation would do would be simply to expand this community health worker program throughout the state, making it a Medicaid eligible reimbursable service. The cabinet wanted some flexibility in looking at the funding, because oftentimes there are federal funds that come in that dictate how the funding should be structured. We also put in the bill that we are directing the cabinet to look at things like a state plan amendment, waivers, looking at other ways to fund this program, and not necessarily have it be strictly Medicaid. So that's really what this does. It also addresses the healthcare worker shortage. We all know that we have a real problem with our healthcare workers in Kentucky, And this will, in this legislation, we are partnering with KCTCS to allow and grant college credit for certification through this program. So that's really what this bill does. I'm very excited about it, and I think I'll just hand it off to, would you like to go ahead and just let Emily introduce herself, and we can kind of go around the table just briefly.
Thank you very much. Good afternoon. And thank you again, Chairwoman Mosier, for sponsoring this bill. Thank you, members of the committee, for having us here today to speak about just how valuable community health workers are for Kentuckians, for the health and well-being of Medicaid members. This bill, House Bill 525, creates a very, very important pathway to expand our current network of community health workers. As Representative Mosier said, we've had community health workers in Kentucky for decades, but there has not been a sustainable funding source for community health workers. And this bill creates a pathway to have many more.
You need to introduce yourself for the record.
Oh,
sorry.
I apologize. Emily Beauregard. I'm the director of Kentucky Voices for Health. And we have been working to find an opportunity to reimburse through Medicaid for community health workers for many years now, since it became an opportunity through the Centers for Medicaid and Medicare Services. And so having this bill allowing CHWs to bill for Medicaid services and to provide these services to enrollees is a real game changer. There is nothing that is more patient-centered than having a community health worker as part of your care team. And there's nothing I can say about CHWs that CHWs can't say better themselves. So I have with me today many CHWs and program administrators from around the Commonwealth who are here to tell you just a little bit about the work that they do every day in their communities, the impact that it makes. And I'll invite Pam to start.
Sure.
If you'll
motion on the bill. I'm Pam Spradling. I'm the Director of Strategic Planning.
There. And then
Oh,
also there
it
is
was
a
green,
motion
but it
on
wasn't
the
lit
bill.
up.
So,
Representative Mosier, you've got a motion and a second. Do you want to let your guest speak, or how do you want to do that?
we do have a motion and a second.
Go for it.
All
If
right.
you're confident.
Yeah, I think we're fine unless anyone has any questions.
Okay.
We're happy to
Did you get
answer
the who to go
questions.
motion and second? Okay. Representative Fleming has a question.
Thank you, and I would say with a heartfelt thank you for everything that y'all do in the community to help elevate people to have a better life, not only for themselves but also the family. I'll go on the limb that my appreciation and thanks is felt by all the committee members of what y'all do. You're very in the forethought of our mind to make sure that y'all are taken care of, not only from a pay but also from a tool to provide those services. So I just want to say thank you very much for all you do. You've got a good champion there with the Chairwoman Mosier in terms of pushing this thing through to help out. I do have one question. It's a little bit off, but it's still germane. We recently passed out of the House, and it's going through the Senate, House Bill 127 about Tim's Law. And as y'all might know, it's a court order process. Are y'all being utilized, or do you know much about it in terms of providing that type of a care for individuals that have severe mental health, to make sure they're on medication, make sure there's a wraparound services, all that? Can y'all comment on that? If there's, because I'm hearing some information like it's not out there as much as I was hoping.
Okay, sure will. I think I can speak to that to start, but I'm sure the community health workers themselves probably have anecdotal stories that they can tell about that as well. I'm Pam Spradling. I'm the Director of Strategic Planning and Development for Big Sandy Healthcare. We're a federally qualified health center operating in 5 counties in eastern Kentucky. And I can say that, yes, we work with patients primarily with chronic conditions, and we consider mental health conditions also chronic conditions for many patients. So those patients with severe mental health, mental illness, issues, we do work with those patients, and we provide pretty much the same services for those patients that we would someone with diabetes or asthma or chronic heart disease or whatever condition. So yes, we do work with those patients, and we just as we would work on not only clinical issues but also helping those patients to reduce barriers that they might have in accessing health care. And as Emily mentioned, and Representative Mosier also mentioned, some of those issues are just the fact that they don't have transportation to get to a medical appointment or a mental health appointment. They can't afford their medications, and some of the mental health medications that are prescribed are very expensive. So helping those patients access that medication, helping them to separate out their medication into a pill box, once a week or once every couple of weeks, helping them grocery shop, have access to healthy foods, helping them access social support and help to develop their health literacy level a little bit more. All these are issues that, while we may not think of them necessarily as clinical issues, community health workers, they can expand. I always call community health workers the cherry on top of the clinical services that we provide, because they're just that extra, little bit extra service that so many of our patients need. Sometimes I tease because I'm always pulling my community health workers into my own health care. Can you call about my medicines? I'm not sure when I was supposed to pick them up or whatever. And, they help me navigate the process, because it is a very complicated structure of healthcare and social services that we have in these days. And so community health workers can really make the difference in helping people access services, clinical services, or social services in the community. So, did I answer your question?
Yes,
hope that
ma'am.
I did.
And I have one more, just follow up real quick comment. And I hope the audience and those of the committee and people looking on KET, this is the grassroots bare knuckles approach to helping people out. And I can't thank y'all enough. Representative Wheeler and I really pushed that bill pretty hard because I see the value, and we're looking at 1,800 more people that could be serviced under the TIMS law. So I just want to say thank you very much. Your voices are being heard, and we're trying to react.
Can I add one thing
Yes,
about
ma'am.
the mental health question? I think
ma'am.
another thing
Just
that
introduce yourself. Okay?
Yes, my name is Celine Mutier Maria. I am a community policy strategist at the Louisville Urban League, and I've worked as a community health worker for 3.5 years, and I'll always be a community health worker. But one of the other things about mental health is that oftentimes the communities that we serve have been underserved for quite a while. They have not had access to health services for various reasons, and so sometimes there are certain stigmas associated with certain types of health care, and especially mental health care. And as a CHW, we're able to connect with patients on a different level and really be able to normalize getting treatment for mental health, and it makes them more open to exploring those issues. And then also what lessons are learned in that mental health treatment, we're able to support them in the community. So applying a lot of their things that they learn in their treatment plan, and how does that look for them in the community, and really offer that feedback loop for the provider and the patient to continuously improve their treatment plan. So I just wanted to make sure to highlight that we really help to reduce stigma around mental health care.
Thank you. Thank you, ladies, and thank you, Madam Chair.
Seeing no further questions, Madam Secretary, please take the roll.
Representative Bentley?
Yes.
Representative Bowling?
Yes, explain my vote. I want to thank Chairman Mosier for bringing this bill today, and I certainly want to thank you all sitting at the table for all your work, everything you do. I'm making my yes vote on behalf of Ashley Shoemake-Killian, who works out of a clinic in Lexington, does great work, but she was my next door neighbor growing up, and
That's good.
I'm proud of everything you do, Ashley.
Representative Bray?
Yes.
Representative Birch? Representative Dotson?
Yes.
Representative Elliott?
Aye.
Representative Fleming?
Aye.
Representative Fraser Gordon?
Yes.
Representative Marzian? Representative Gibbons Prunty?
Yes.
Representative Rayburn? Representative Raymond?
Yes.
Representative Riley?
Yes.
Representative Sharp?
Aye.
Representative Sheldon?
Yes.
Representative Tate?
Yes.
Representative Weber?
Yes.
Representative Westrom? Representative Wilner?
Yes.
Chairwoman Mosier?
Yes.
Passes favorably and should do so on the floor. So congratulations and good luck moving forward. Thank you. Thank you, ladies, for being here.
Thank you all. Thank you so much. It's wonderful.
Those emotions got excited.
Now we will take up House Bill 430.
Right. Okay. Thank you so much.
Your guests
like
may
to
make their
invite
way
my
to the
guests.
table.
Thank you.
Would you like to address the sub first, or?
Yes, we do have a committee sub that I would like to adopt.
Second. Motion and a second on the sub. All in favor say aye.
Aye.
Likewise. Passes, sub passes. Proceed.
All right, thank you so much. Let me move my microphone a little closer. So this is a very short but a very substantive bill. I am Kim Mosier, State Representative of the 64th District, and I do have some guests with me today. I will just give a brief overview, and I'll then allow them to introduce themselves and expound upon this legislation. So we are here today to talk about House Bill 430. And I think as a committee, we deal a lot with Medicaid issues. We don't necessarily talk about Medicare very often. It's a federal insurance policy available to individuals who are generally 65 and over. There are some provisions in federal statute that allow through the Social Security Act individuals with end-stage renal disease to apply for and have Medicare as their health insurance policy. So just as a general kind of overview of what Medicare is. The Medigap policy is what we're talking about today, and that is a supplemental policy. It's something that individuals can purchase in addition to their original Medicare. Medicare is a little complicated. I mean, there's Part A, which is hospitalization, Part B, which are really your doctor's visits, and then Part D, which are your prescriptions. And then there are all sorts of other rules around Medicare that we're happy to get into if people have questions. But the issue that we are looking to solve with this legislation is that the Medigap policies are available when you first enroll in Medicare, but if you wait 6 months, you sign up for a different policy and you decide that you want to have Medigap coverage or a supplemental policy. And incidentally, there are 59 different policy writers for a supplemental insurance in Kentucky. So that just tells you how many varying opinions you might get when you go to sign up for this policy. But anyway, the issue at hand is there are questions around pre-existing conditions if you wait longer than this 6-month period. It's kind of an arbitrary length of time. We think that it's discriminatory, and we would like to tighten that up and allow folks more options. Now, what the committee sub does is we have had many meetings, several meetings with the Kentucky Association of Health Plans and health insurance plans folks, and have discussed some of their concerns. And one was around open enrollment. It's problematic to be able to sign up for this supplemental policy at any time during the year, and I understand. I mean, we don't want we wouldn't want folks to get homeowners insurance when their house is on fire, right? We don't want people to be able to just get health insurance when they have an issue. And so we tightened that language up, and we're using what's called the birthday rule. And I know that Elizabeth will be able to expound upon that a little bit, or maybe Eric. And then the issue of premiums, we are using what's called average weighted premiums, and it's a formula to calculate what a person's premium would be using age, not necessarily pre-existing conditions. So it's not truly medically underwriting, but it's giving the insurance providers some ability to average out those premiums so that it truly is a compromise. So that is what we seek to do. I would like to introduce, I don't know who wants to go first. Okay, Elizabeth. So just if you could introduce yourself for the record and proceed.
Thank you,
And
Chair
thank you
Moser.
for being here.
Thank you. My name is Elizabeth Lively. I am the Eastern Region Advocacy Director for a nonprofit patient advocacy organization, Dialysis Patient Citizens. Our organization is patient-led. It's free membership. We have just under 500 Kentuckians who are members of Dialysis Patient Citizens. And our membership is open only to dialysis patients, kidney disease patients, and members of their families. What's important about our organization is our mission and our policy are patient-led by our members and by our board. And our board of directors, every single member of our board is an end-stage renal disease patient. I'm testifying today in support of House Bill 430, which would provide access to Medicare supplement plans, also called Medigap, for dialysis patients who are under the age of 65. The bill also provides key consumer protections and affordable premiums. Now let me describe to you the universe of kidney failure patients. These patients comprise an extremely vulnerable population. Nearly half of them are also on Medicaid. They're called dual eligibles with both Medicare and Medicaid coverage. In Kentucky, there are 9,047 dialysis patients as currently reported by the U.S. Renal Data System. Of that number, 5,245 of them are under the age of 65. The interesting thing about kidney failure, to stay alive, you only have two options. That means multiple dialysis treatments every single week of your life or a kidney transplant. There's no other options. There is no treatment that will cure end-stage renal disease. Also, kidney disease and dialysis disproportionately impacts communities of color. African Americans are 3.5 more times likely to have kidney failure. Hispanics, Asians, and Native Americans 1.5 times more likely. So fair and affordable access to Medigap coverage for underage dialysis patients is critically important. And I want to talk about two main reasons why it's critically important. First of all, it provides dialysis patients with greater financial security. You become eligible for Medicare in two ways. You turn 65, or upon diagnosis of a disability or end-stage renal disease. But even with Medicare coverage, patients are legally responsible to pay their 20% coinsurance. There's no cap on this, and the ticker starts again on January 1 of every year. So these out-of-pocket expenses for dialysis patients can be up to $20,000 a year that they are responsible for paying. Medigap covers these out-of-pocket expenses, eliminating this struggle. Do I pay my medical bills? I need my medical treatment to stay alive. Do I buy food? Do I pay rent? It's not hard to understand that people will spend down their assets to qualify for Medicaid, becoming a dual eligible for both Medicare and Medicaid. The state pays for the 20% out of pocket. The second reason is a life-saving reason. While some patients are okay on dialysis, the optimal therapy remains a kidney transplant. It often adds years and provides a higher quality of life. And dialysis patients who often cannot work following a kidney transplant are able to rejoin the workforce, which is really important for the economy of the state. Currently, there are 617 Kentuckians on the kidney transplant wait list who are under age 65. That's the optimal age for a transplant. So this is the list that's maintained by the Health and Human Services by the federal government. But there's a different list. It's called the active kidney transplant wait list. You get on that list at your transplant center following an extensive, obviously, medical screening to make sure you're healthy enough for the transplant and the organ will survive, and also a financial screening. The reason for that is the 20% out of pocket needs to be covered so that these patients can continue to receive the medical care that they need. This helps the kidney to have the optimal survivability. These organs are very, very scarce. I learned this firsthand when I worked for an organ procurement organization. The transplant center nor the dialysis patient needs to be strapped with this financial responsibility. So you're only put on the active list if you have supplemental or if you can come up with the 20% for the transplant surgery. That's around $150,000, so you can do the math on that. I've witnessed this firsthand in other states where we have worked on Medigap coverage. In Rhode Island, for example, the sponsor of the bill that's currently working its way through the Rhode Island General Assembly, one of his family members was under age 65 on dialysis, had purchased a Medigap plan. Rhode Island is exactly like Kentucky, nothing in place for under age 65. The insurers were not regulated. She was dropped. She was then dropped by her transplant center on the wait list, so she had to start that all over again. We've heard the same story in Massachusetts. We've heard it in Alabama. So this is a true issue, and Medigap coverage does provide life through kidney transplants. So it's clear that access to fair and affordable plans can transform the lives of these under 65 dialysis patients. But what's going on in Kentucky right now? So currently, some plans are available for purchase, but because the Commonwealth doesn't have any statutory authority in place, insurers have broad parameters for how they deal with the under 65 market. First, plans are all medically underwritten. This means all pre-existing conditions are taken into account when an under age 65 individual applies for coverage. Because they're not regulated, carriers can refuse coverage. They can cancel coverage, as I've explained what happened in Rhode Island, and charge higher premium rates. Medicare.gov has a supplemental insurance online tool. So for example, monthly premiums for Plan A, which is the leanest benefit plan, for under age 65, ranges from $248 a month to $1,118 a month. In contrast, that same plan, if you're 85, is from $126 to $510 a month. So if you're under age 65, you're paying 119% more than an 85-year-old for that same coverage. Congress in the 21st Century Cures Act did provide access to under age 65 to the Medicare Advantage plans, effective in 2021. However, most of these plans still require the 20% coinsurance. And in rural areas, it can be a real issue for network adequacy because if a medical provider isn't included in the Medicare Advantage network, then that enrollee ends up paying a higher cost for those medical treatments. But here's the ultimate question. What will happen to premium rates in the Kentucky market? So to help answer that question, we commissioned a study to take a look at this. And Health Management Associates out of Michigan looked at all of the states. They looked at the state experience. They used Medicare claims data, and you all should have a copy of that report. So how many people are going to be covered by this? Of the 5,245 under age 65, that includes people who are still working, people who are on Medicaid, people who are on Medicare Advantage. They're not part of this equation. The numbers of people who are part of this equation is less than 1,500. Those are individuals under age 65 who were covered solely by Medicare. The analysis shows that if all Medigap carriers in the Commonwealth were required to provide policies according to the language that's in the substitute amendment, the estimated overall premium in Kentucky for the pool, the whole pool, would increase by 0.9%. $2 a month per person increase in their premium, less than a 1% increase. For dialysis patients, their estimated premium would drop 35%. So the compromise language that is in the substitute amendment really is a win-win, giving something to the insurers, but also providing a ginormous benefit to these individuals. Currently, 30 states require at least one plan for under age 65. 17 of these states limit the premiums. The neighboring state of Missouri has had this protection in place since 2009, and the compromise language that is included in this bill is what the state of Missouri is using. I sincerely hope that Kentucky will join this group of states and do the right thing for their residents. So I ask your yes vote in support of this bill. Thank you.
Thank you.
Just before you start, We don't have the study in the packet. The staff doesn't have it. So if you could send it via email, they can get it out to us. Okay.
All right, will do.
Thank you.
I'm Eric Evans, Associate State Director of Advocacy and Outreach for AARP Kentucky. I'd like to thank Chairman Moser for bringing this bill and before you all, and also Representative Wilner for working with us on this bill. This is one thing that AARP really finds an important issue. AARP is a nonprofit, nonpartisan organization with membership of more than nearly 38 million. We have 430,000 members just in Kentucky. AARP fights for issues that matter most to our folks. That means family health care, family caregiving, independent living, and financial security, which this bill covers 2 of those. So House Bill 430 will require Medigap plans to cover people with pre-existing conditions. AARP has been made aware of this by many of our members that have been denied coverage. And so we, along with Chairman Moser, saw this bill as a great way to fix this problem. Under current federal minimum standards, consumers who purchase Medigap only get one opportunity, as we said, to enroll when they first join Medicare. And many of our folks have a tough time, figuring that out. Many people don't realize that once that initial 6-month window passes, consumers can be denied coverage or charged much higher rates based on their pre-existing conditions or other health status if they try to get into another Medigap plan. So AARP obviously has advocated for limiting pre-existing conditions in the past and more access to health care, and we just see this as a great way for folks that are some of our most vulnerable Kentuckians. And we would really like your support for this bill.
Motion on the bill. Do we have a second? With the sub? Okay, Representative Marzian. Before we vote, we're going to entertain a few questions, and then I know we have a few folks that want to speak against it, so we want to give everybody adequate time. Representative Bray, did you have a question?
Yeah, I've got a couple, just because, we've not dealt with Medicare before, and so I'm kind of swimming in water that's over my head here. But so I'm very sympathetic towards patients with end-stage renal disease. My dad actually gave a kidney to my aunt because, she suffered from that. But my question on this is, so this Medigap insurance that we're talking about here, does that only qualify for people with end-stage renal disease, or is that a broader group?
It applies to anyone who is eligible for Medicare.
Okay.
So, the end-stage renal disease is an example of the non-age eligible patient.
And then disabled. Yeah.
And folks who are disabled.
All right. In Section 2, it talks about the weighted average for premiums. I guess it's so that people aren't discriminated on based on their age. Do we have these policies similar to this in place for other insurance plans?
That would be, those are private insurers who set the terms of those policies. So I don't know that we have. Are you asking if they are medically underwritten?
Yeah. So, like for other medically underwritten plans, do we have some kind of weighted average like this in place, or is this something new? Or
I believe it's new to this issue.
Okay.
So.
All right. And then just, has there been like an actuarial analysis done on this, or?
Well, we don't have an LRC, state fiscal impact study, but we do have the national analysis that was just talked about, and we'll make sure that you have that study. But awesome. That's what showed that the premiums for under this provision would go up 0.9% for individuals.
Okay, thank you.
Representative Bentley.
Thank you, Chair Lady. My first question is there a health mandate on this?
No, we don't have a health mandate on this yet. We can do that. Elizabeth, I don't know if you want to speak to what that looks like or the fiscal impact. I mean, we're not talking about any state dollars. What this allows is individuals to continue paying their own premiums. We're just making sure that it's not exorbitant and out of reach for people to stay on their own Medigap policy and not have to move or spend down all of their assets to become Medicaid eligible. So I think what it would show is the fiscal impact to the state would probably be zero. I don't know why it would be more than zero, because we're not talking about state dollars.
Then, have you asked the Department of Insurance how they feel about it then? Do they have no response since there's no state funding, or what?
We haven't had a conversation with DOI yet, but we have had conversations with private insurers, which is who this would affect.
And my last question.
Mm-hmm.
You know, being in business for 50 years as an independent pharmacist working for other people, it seemed like every time I got involved with the federal government or federal program that I was in violation if I tried to override it. Does this violate any federal laws?
No, it doesn't. There are provisions in federal law that allow states to make these sorts of adjustments.
Thank you, Chair Lady.
Mm-hmm. You're welcome.
Representative.
Yeah, just a clarification. I think it was mentioned, you mentioned like 59 plans that are offered under Medigap.
Well, there's 59 separate carriers
59
who
separate carriers.
offer a supplemental
Some type of supplement.
insurance. Mm-hmm.
And you said it was 0.9, and that equates to, I think you mentioned earlier, maybe not in this setting, but $2 an increase per individual, roughly?
Yes. Mm-hmm.
Okay. All right, I just want to try to get some clarification, because obviously I got a pretty good number of folks over 65, which I think like I'm getting closer and closer each day. So I've been mindful of that. So I just want to make sure that there's really no, if not extremely minimal increase in terms of these supplemental plans and so forth.
Right. The analysis has not shown that there's a substantial increase in premiums.
Representative Marzian?
Thank you, Madam Chair. Thank you for this bill. And if I remember correctly, did you not have a bill a few weeks ago that helped or had charitable organization could raise money to help pay for?
Yes.
And would that apply to this?
Yes. The charities would be able to pay premiums on behalf of Medicare patients. Mm-hmm.
Thank you. And just a comment, in my other life I was a dialysis nurse as well as a transplant coordinator. Mm-hmm. And after someone went through the whole workup, which was very extensive and could take months, if not longer, and then to get on the list and then be dropped because of financial concern, because of the coverage, and you know, they not only need it for the surgery but also for the medications, which can probably run thousands a month to keep their kidney. Exactly. So this is so important for that population to be able to get off dialysis, have a life that maybe they can get back to work and have a better quality of life. And if I remember correctly from my years in transplant, it was about a 3-year length of time for the transplant to be in effect and working to recover the cost. And dialysis is very costly as well. Right. So if they can get their medicines and get their lab tests with this Medigap, they're going to keep that kidney longer, and it's a win-win for everybody.
For everyone.
So thank you.
Yeah, thank you for bringing that up. I wholeheartedly agree that the point in discussing the end-stage renal patient is to allow them to get on with life, to become a productive working member of society and contributing to their families. But also the return on investment is probably a huge win for the insurers as well. I would think. I mean, dialysis is lifelong. It's expensive, and I mean, you know, I think to make this adjustment in premiums and make it manageable for patients is a win for everyone.
Representative Sheldon.
Thank you very much. Just a brief comment. Good bill, and thank you very much. I do have a quick question. But would you consider the single issue here really is this thing has been allowed to operate this way in the free market kind of dynamics for all this time, and there's been absolutely no regulation in this particular area. Would that be appropriate?
Yeah, I think so.
There are federal minimum standards, however, you know, they're not subjected to the, you know, the same standards as the Affordable Care Act. Obviously, it allows
Right.
pre-existing conditions and to charge different by age. So,
And those things don't apply to at the moment. Right now, what we're trying to do is we found a little gap in here where there's no regulation. So what happened as a result? You know, we're not selling shoes and shirts and that kind of thing. This is healthcare. This is the good of our citizens, and sometimes it's necessary to step over into healthcare and make sure our citizens, especially since all of healthcare is highly regulated, all the way down to we're reimbursed, allowables, who can provide, which hospital, which pharmacy. So I say, good for you. And this is a place we step over and we say, you can't take advantage of our people anymore. And I appreciate your courage, and I think this is the right thing to do. And I thank you very much.
Thank you.
Okay, we have no more questions at this point in time, so I'm going to ask Scott Brinkman and Rusty Crest to come to the table. Just please introduce yourselves for the record, and y'all may proceed. Whoever wants to go first.
Thank you, Madam Chair, members of the committee. My name is Rusty Crest. And
Turn your microphone on or get it closer.
Thank you, Madam Chair, members of the committee. My name is Rusty Crest, and I'm here on behalf of America's Health Insurance Plans.
And I'm Scott Brinkman, and I'm here on behalf of the Kentucky Association of Health Plans.
Yesterday afternoon, I was, well, first off, let me say it's not a pleasure to sit next to the chair against her own bill, and that's, but we had met with her before and brought her up to speed on what we were thinking from a health plan perspective. And yesterday, we provided you all with an email outlining AHIP's concerns with the bill, and they generally revolved around open enrollment period and the guarantee issue provisions. Haven't had time to fully digest the committee sub yet. I just saw it a half hour before the committee meeting. But at first blush, it still contains guaranteed issue. And guaranteed issue will necessarily increase premiums because it results in adverse selection. Which means that people will, that along with the birthday rule, which is a form, in my opinion, of the open enrollment, will cause healthier individuals to enroll when they need it and leave the more unhealthy folks enrolling early on. And that risk pool is just very, very costly to manage. That way, the unhealthy folks are subsidizing the healthy ones. We're also concerned that it doesn't appear that the enrollment period aligns with the Medicare enrollment period, and the folks at AHIP have some concerns with that issue. And I think the premium, and I'll let Representative Mosier respond to this one, but the premium discussion about $2, that seems to only apply to subsection 2, the non-age eligible folks. And when it comes to the enrollees over 65, that's going to be a whole different number, and I'll be curious to see what what that comes out to be. And with that, I'll thank you very much for your time, and I'll let Mr. Brinkman continue.
Thank you, Madam Chair, members of the committee, and certainly appreciate Chair Moses' work dealing with people who are on dialysis, have renal disease, and certainly Representative Marzian. We did meet with her relative to House Bill 317, and Chair Moses was very, very generous with her time and addressed some of our concerns. The concern we have with the House Bill 430, including the committee sub, is if you look at Section 2, that deals with the non-age eligible persons. This is the individuals who are eligible because they have renal disease. However, if you look at Sections 1, 3, and 4, that applies to the entire Medicare population, everybody over the age of 65. And if you look at Section 1, it builds in the guaranteed issue community rating provisions that in essence say that when you're 65, if you delay obtaining a Med-Sup policy because you're healthy, and then 4 or 5 years down the road you develop a serious health condition, you can come in at that point and obtain a Med-Sup policy, and there's no rating based on your age, gender, or health status, so you get the same premium as that healthy 65-year-old who was responsible, who signed up for a Med-Sup policy when they first became eligible for Medicare. The irony is Medicare for the basic benefits discourages exactly what I said. There are penalties if you do not enroll within 6 months of attaining the age of 65, and that's both Parts A and B. The problem with subsection 1 is it says it creates this incentive for healthy 65-year-olds to delay obtaining a Med-Sup policy until they develop a health condition. And there's no penalty for that delay, meaning that you're penalizing those who are responsible, who do the right thing, obtain the Med-Sup policy when they're 65. The risk pools by all 59 insurers, all based on people signing up for Med-Sup policies at age 65. The market works exceedingly well. It works because you have healthy 65-year-olds signing up for the Med-Sup policies. As they progress and maybe have that severe health condition, they're having the benefit of the coverage because they have paid into the system, and it works because it's everybody's participating. There are incentives to participate, so you have healthy, and then as you go on, you have more severe health conditions. The concern we have with subsection 1, as well as 3 and 4, is that you have a Med-Sup market that works exceedingly well. And I personally participate. I can, from firsthand experience, tell you it works exceedingly well. It's very stable. The risk pools have all been underwritten based on the law as it exists today. And our concern is that we're going to create disruption in this market. You can ultimately maybe result in higher premiums for Medicare eligible seniors. You may have some of our existing plan issuers exit the market because they're going to have to rewrite the risk pools. It's just going to be very, very disruptive. And working with Chair Moser, what we're trying to accomplish is if we could have a very, very targeted bill dealing with her concern, which is totally legitimate, and dealing with this fairly discrete population, the non-age eligible individuals. We want to work with her to get there. But our concern is if you look at 1, 3, and 4, it applies to the entire Medicare population. I think it's going to have a lot of unintended consequences. It has the potential to be very, very disruptive to a market that's otherwise working. And so our ask is if we could either delay for a period of time to focus on the precise issue that Chair Moser is concerned with, which is a very legitimate issue, but also make sure that we eliminate all these potential unintended consequences that as I read the bill, I think are very real and of great concern and could be very, very disruptive to an awful lot of Kentucky seniors who rely very extensively on the stability of the Med-Sup market. Madam Chair, members of the committee, thank you for allowing me to testify.
Madam Chair.
Yes, if I could just respond. And thank you very much for your conversations about this. I do understand the issue a whole lot better since I've really had to educate myself about Medicare. There are a lot of moving parts, and I have told you, Mr. Brinkman, that I am, or I should say Secretary Brinkman, or Representative, that I'm willing to work with you on this on this language. So thank you for bringing your concerns to us, and I am willing to look at this. I still maintain that there are protections that we should put in place for individuals. So that's kind of where we are.
So what's your pleasure?
Well, I would like to go ahead and vote this out today and work on an amendment with these gentlemen. So,
are there any other further questions? Representative Elliott?
Thank you, Madam Chairman, and thank you for this bill. I think it is a very laudable goal.
Is your mic on, Representative Elliott?
Pull it closer to me. How much will this raise premiums? Because I think that's kind of you heard the testimony that it would, from the national study that we haven't seen, that it would go up about, I think, 1%. 0.90, I think, was the number. Do you two agree with that?
I do not have the answer to that.
That's the concern here, though.
It is a big concern. We just don't know any exact numbers, and that's the beauty of the way our system works here. We've got the health mandate analysis that'll eventually come out that'll be able to tell us. But I could certainly ask.
Could you speak up?
I could certainly ask our client.
Sure. And if I might inquire with one other question, if the pre-existing condition limitation or exclusion were removed, would your groups be supportive of this?
We'd have to circle back on the open enrollment and make sure that it aligns and any concerns are addressed. I wanted to speak, primarily about how I think this could be very, very disruptive to the market because of the guaranteed issue and community rating features. But that's certainly we'll circle back and get back to you on that point. And Chair Moser's right. Medicare is a federal program. There's no state dollars involved, but the Med-Sup policies, those are private insurance policies, and so I think it would be appropriate to have a financial impact statement prepared by the Department of Insurance, because like any health insurance mandate where they do the analysis and say, if this becomes law, this could have the possibility of raising premiums by a range of between X and Y dollars per month per member. I think that would be totally appropriate because this is private insurance, and I think it would be appropriate to have that analysis done that if you have guaranteed issue and community rating for the entire Medicare population in Kentucky, what impact that would have on premiums, on the Med-Sup premiums of the policies issued in the state.
Thank you.
Representative Sheldon?
Yes, thanks again for you guys, your thoughts on this. Let me ask you now, I guess we categorically are saying that premiums are going to go up at that table there, and we just got asked, do you have any kind of study or data showing that? I guess I'm a little concerned. We hear a lot about, well, that's going to cause premiums to go up, and there's some good things here, and I agree with the direction everybody's going here. I think you need to work together and figure it out, but it concerns me, when we, for instance, how many people, you said that it would include all the rest of the people in Kentucky, and I can see where that would cause some eyebrows to go up, but how many people would that include? So I guess one, why are we categorically saying premiums are going up? Is it common sense you're using? Are there other states that have done it and you've got the data in your back pocket? I just want to know.
Yeah, 2 and maybe 3 other states have passed similar legislation applying to the entire Medicare population. Connecticut, New York, possibly Maine. We're trying to drill down. A part of our problem is that we really don't have all the answers. And you raised, Representative, a very legitimate question, which is why I think it would make sense for DOI to do the financial impact analysis to know. And again, we're not here. If it has no impact on premiums, you ought to know that. If it has the potential to raise premiums 10%, you ought to know that. And that's why our concern is we don't have all the data, including DOI weighing in on the effect of this legislation.
And I'll just follow up with this. Then I don't know that we should be coming out and sending out things, telling everybody the premiums are going up, when you just said you don't know. New York don't know. Other people don't know. You don't have the data. I do agree you should do the health mandate, and let's see what it is. But, it's a possibility, I suppose, and a possibility along the way. But I won't keep we won't keep going down this road.
Sure.
I'm glad y'all are going to work together, and I appreciate you being here. Thank you very much.
Marzian?
Thank you, Madam Chair. good to see you, Scott. Can you tell me how much out of each dollar that is paid in insurance is paid for actual services and how much has gone to administration and CEOs, and how profitable the health insurance industry is?
I don't have that data, Representative Marzian. I know that in the Medicaid program, the MCOs are required to achieve a 90% MLR.
In Medicaid.
Medicaid,
Correct.
but in the private insurance market, I do not have that information, no.
So in the past, it had been about 20% with CEOs making millions and flying airplanes around, and so it's hard to feel real sorry for the health insurance industry.
But the rates are regulated by DOI. I mean, it is, so I mean, the rates are set.
It's still hard to feel real sorry for them.
I actually do have a graphic. I don't have it with me that sets that specifically out. I will send that to you just as soon as I get it.
Send it to the whole committee if you don't mind.
Absolutely.
I just have one question, Mr. Brinkman. If Missouri has done the language in the committee sub is from Missouri and they've done it since 2008 or 2009, that would help shed light.
Again, if Section 2 is based on Missouri, we have not done an analysis of that. And again, we appreciate the concern with this small subset of the Medicare population, and certainly appreciate Chair Moser's focus and compassion for this group of individuals. We all share the compassion. The problem is this committee sub is not limited to just that population. If you look at non-age eligible persons, they are within the scope of Section 2, but Sections 1, 3, and 4, as I read the committee sub, apply to the entire Medicare population, and that includes all the people 65 and older who participate in the med sub policy marketplace, if you will. That's our concern. It's not.
I hear your concern. I
people with
was just wondering if if Missouri wouldn't have some data for you, but that's my only question.
Again, I saw this about an hour. Well, I saw this about 10:30 in the morning, so I don't know. And we'll certainly look into that to see what the experience of Missouri has been.
Okay. Appreciate the fact that you are willing to work together, and seeing no further questions, Madam Secretary, please take the roll.
Representative Bentley?
I think that we really got to work together on this, to get it right, cleaned up. So I'll vote yes to get it out of the committee, but I can see where we're going to have to work on a lot. Thank you.
Representative Bowling?
Yes.
Representative Bray?
Explain my vote. May I explain my vote?
Yes.
I'll vote yes to get it out of committee, but this has got a long way to go. I get really, really uneasy when we start talking about regulating the free market, especially when we're talking about raising insurance rates, and the statement is, we don't know how much this will impact. So I'll vote yes to continue the conversation, but I do look forward to the actuarial analysis. Thank you.
Representative Birch? Representative Dotson?
May I explain my vote? I've heard the disparity on both sides, and I see clearly both sides of the picture. But I think you'll find that Chairwoman Moser is very fair and open-minded, and I appreciate the fact that you're willing to work with them. So I vote yes.
Representative Elliott? Representative Fleming?
I'm going to join Representative Bray and Bentley on voting aye, but I'll reserve how things will materialize, and I have both confidence in the chairwoman as the secretary. I've known them for a long time. They'll come up with a solution. So I look forward to seeing that, but I'll vote yes, but reserved yes.
Representative Frazier Gordon?
Yes, and I look forward to the amendment as well.
Representative Marzian?
I vote yes, and I'll bring a big box of Kleenex tissues for the insurance company so they can be crying over their loss of 50 cents.
Representative Gibbons Prunty?
Yes.
Representative Rayburn? Representative Raymond?
Yes.
Representative Riley? Representative Sharp?
Aye.
Representative Sheldon?
Yes, and I agree with Mr. Brinkman about that. You do understand the intent of the law, and we're looking forward to seeing what you guys come up with. Thank you.
Representative Tate?
Yes.
Representative Weber?
Yes.
Representative Westrom? Representative Wilner?
Briefly comment, if I may.
Yes.
Thank you. I'm a yes. And of course, I understand the chairwoman's intent to protect the small subset who are the underage folks who qualify for Medicare because of particular health conditions. But I hope we don't leave out the people who are 65 and older who have been excluded because of pre-existing conditions and because of missing that very narrow window. So I vote yes, and I look forward to seeing the compromise. Thank you.
Chairwoman Mosier.
Yes, ma'am.
Passes favorably, and we'll see what it does on the floor with the amendments. But thank you. Thank you all for being here.
Thank you.
Thank you for the conversation. Motion to adjourn. We are adjourned.